Okay. Thank you again to the chairpersons, and it is a sponsored session by Zydus, and the slides have been provided by them. I will be talking about early breast cancer, majorly HER2 positive breast cancer. So if you see this slide, it clearly shows that the chances of recurrence in a HER2 positive breast cancer in the early years, but also if you see decade by decade, as we are escalating the anti-HER2 therapy in a high risk HER2 positive breast cancer, we are definitely able to reduce the recurrence in the initial years. And the data in front of you clearly shows of the comparison of 1990 and 2004, 2006 that yes, there is a reduction in the early relapse. As the time has gone by, I think the whole house will acknowledge these statements that we have actually gone a long way in the advent of HER2 targeted therapy. The studies started with the HERA and NSCPP group of trials where we talked about 1 year of adjuvant trastuzumab. Then we did talk about 6 months of adjuvant trastuzumab. We also explored the field of neoadjuvant trastuzumab, extending it to neoadjuvant trastuzumab and pertuzumab. And we also realized that yes, PATH-CR has some meaning to the mind of the treating team. It may go into IDFS, yes, that data we have, but whether it is converted into OS, that we don't know. So when we give a neoadjuvant therapy in a HER2 positive breast cancer, I think these all principles which we have learned over the last 10 years do apply to triple negative and HER2, that we facilitate BCS, can render inoperable tumors operable, we can achieve pathological CR, go for a response adaptive therapy. And I think the last 2-3 lines are very interesting, that we give time to the patient to plan for BCS, and also the genetic testing which take 2 to 3 weeks. And if someone after the BRCA positive, a female, deserves a risk reducing surgery, that can also be opted for while the patient is on neoadjuvant therapy. Starting with the NeoSphere data, it was a phase 2 trial. It was a registration trial for pertuzumab neoadjuvant approval. The primary endpoint was PATH-CR, and you can easily see that the intention to treat population, the PATH-CR improved by another 15%, but this was majorly driven by a node positive, 21 versus 40%, almost doubling of PATH-CR. Whereas in a hormone positive subgroup, if you see the comparison of trastuzumab dosi versus pertuzumab trastuzumab, the difference is not much. It is only 6%. So when we talk about NeoSphere and PATH-CR, it is majorly a node positive or a hormone negative subset which is driving this PATH-CR doubling. Trafina was another phase 2 trial. The primary endpoint of trial was the cardiac safety. And we learned 2 things from this trial, that yes, giving a dual targeted trastuzumab pertuzumab is safe. And second is, apart from an anthracycline sequencing with a paclitaxel and trastuzumab, we can also use a TCHP regimen, that is docetaxel, carboplatin, trastuzumab and pertuzumab. So I think we have learned till date that anthracycline free regimen can be opted for. TCHP is one of the standard lines of treatment. Residual invasive disease is an issue. And from there we go to the adjuvant trials of TDM1 and neratinib. TDM1 got approval in 2019 for an adjuvant setting. There was an affinity dataset which gave approval in 2017 of using a dual trastuzumab pertuzumab. And neratinib, which we talk less because we don't have that drug readily available in Indian market, is also approved to be used in the adjuvant setting after you finish the standard anti-HER2 therapy. Coming to the Catherine, I think we have gone through this slide multiple times. I will just rush through this slide. It is basically a T2, as well as majorly the trial was T2 or node positive breast cancer who had a residual invasive disease after being subjected to a chemotherapy with trastuzumab or a chemo trastuzumab pertuzumab combination. The primary endpoint was IDFS. They were subjected to TDM1 and trastuzumab for a total of 14 cycles. This was a phase 3 randomized trial. The IDFS advantage, if the patient is not able to achieve PATH-CR and they were subjected to adjuvant TDM1 for 1 year, vis-a-vis the continued trastuzumab, was 11%. We can definitely debate that if we continue trastuzumab and pertuzumab in this subset, what was the percentage advantage? We don't have that data set. What was good that apart from IDFS, there was also reduction to some extent, not majorly, in the distant as well as loco-regional recurrence. This, what is to be remembered from this exploratory analysis was that this advantage is not only to the trastuzumab, but also to the patients who have been subjected to pertuzumab and trastuzumab. But yes, the major data set, 80% was pre-operative trastuzumab with chemotherapy. Coming to the subgroup analysis, fortunately, all the diamonds are in the favor of adjuvant TDM1. Only one where the confidence interval is wide. The numbers are so less. These are for elderly patients more than 65, but you can see the numbers in total are only 110 or 120, and that's why you have a very wide confidence interval for elderly females. Otherwise, all of them have their diamond in the favor of adjuvant TDM1. The other endpoints were met. The overall survival was a secondary endpoint, and that has not been met. And also, the data is immature. I think, to my mind, only 25 or 30% of the events had happened by the time when this data was presented. Coming to the adverse events, giving adjuvant TDM1 is a bit funny that it has much more toxicity, and that can be easily seen by the discontinuation rate. If you see, the discontinuation rate of trastuzumab group is only 2%, whereas the discontinuation rate of adjuvant TDM1 is 25%. I'm sorry, it is 20%. So definitely when we give TDM1 in the adjuvant setting, there is slightly more toxicity, and this toxicity is mainly thrombocytopenia, and also there were some abnormal liver functions derangement. Yes, with this trial data set of Catherine, it is there in as well as in NCCN as well as in ESMO and other regulatory guidelines that in a patient, whether it is HR negative or HR positive, once they are not been able to achieve PathCR, they shall be subjected to adjuvant TDM1. Now, in this subset, once we think of other trial data sets which we have and the approvals, the second approval which is there is of adjuvant trastuzumab and pertuzumab. Affinity, we are all aware. I will not go into the detail, but this was purely an adjuvant trial data set. And in this, the patients were subjected to chemotherapy with trastuzumab or chemotherapy with trastuzumab and pertuzumab for total 1 year. The primary endpoint was again IDFS, and the total follow-up at 6 or 7 years, the difference is 4%, and this is IDFS. If you see these two slides, it is clearly visible to the house that this difference is being driven by node positive and not node negative patient. Also, there was not much difference in hormone positive and hormone negative. So after affinity, the second data set which we have of escalation of HER2 therapy in the adjuvant setting is neratinib. Here, one of the typical thing in the trial was that they had finished 1 year of adjuvant trastuzumab, and then another 1 year of oral neratinib was given. And these were all stage 1 to stage 3 breast cancer patients. And within 1 year of finishing their trastuzumab, they shall be subjected to adjuvant neratinib. And again, there was a 4% IDFS advantage. And this advantage is mainly for the patients who were hormone receptor positive or node positive. Coming to this conclusion slide, I think as of today, there is no doubt that anyone who has T1A, T1B, or even T1C in Indian context will go for surgery, and then they will be subjected to adjuvant trastuzumab and paclitaxel regimen. We can abbreviate chemotherapy, but we can't abbreviate trastuzumab. Or we can give full anthracycline and taxane, and we can abbreviate trastuzumab to 6 months. That is for a node negative patient less than 2 centimeters. Anything which is more than 2 centimeters or node positive, I know we debate with our surgical colleagues quite often, and they do put their point of giving the BCS because of lack of OS advantage and subjecting them to surgery first. But more said and done, if you have to adopt a pathway of pathological CR and you believe in pathological CR and response adaptive pathway, and the guidelines say that anyone who has more than 2 centimeters or node positive will be subjected to a new adjuvant regimen, which will be chemotherapy along with trastuzumab and pertuzumab. Once you give your strong best regimen, if they are not able to achieve pathological CR, they will go on a Catherine data set of adjuvant TDM1. And I will leave it here open for Nitesh comments when he gives his comments that whether he would like to give neratinib after this or not. Now, when you are not able to, this is when you are not able to achieve PATH CR. If you are able to, this is the last slide, sir. If you are not able to achieve PATH CR, again, among the medical oncologists, we are always divided that whether we give both trastuzumab and pertuzumab or we continue trastuzumab once a pathological CR is achieved. If you believe in affinity data of 3.54% and you have a node positive patient to begin with, and then he has been able to achieve PATH CR, I think most of us will put them on a combination of 1 year of dual targeted therapy. Otherwise, you can continue trastuzumab alone for 1 year. And then after this, would you like to give neratinib or not is again an open question. And with this, I would like to come to the end of the talk and thank you for patient hearing.